Hello, I'm Dr. Richard Becker. It's my pleasure to welcome you to the University of Cincinnati College of Medicine's Scholarvision. Today we'll be discussing an emerging topic of importance, that is cardiovascular oncology. I'm joined today by Dr. John Lynn Jeffries from Cincinnati Children's Hospital Medical Center and its Heart Institute. Dr. Jeffries, welcome to Scholarvision.
Thank you for having me.
It's a pleasure to have you. And this truly is an emerging field of cardiovascular oncology, and perhaps you can tell our viewers just a little bit about what it is.
Sure. So cardio-oncology really, in my mind, is a multidisciplinary approach to the cardiovascular disease that is secondary to those patients that have cancer and receive therapy. Obviously, a very important topic, both independently important, cancer and cardiovascular disease. And we're having great successes treating cancer both in childhood and adults. However, many patients do not recognize that their long-term prognosis is very carefully married to their cardiovascular outcome.
Yes. And I know in the adult world, it's been predicted that there are approximately an additional 1.5 million cancer survivors.
Correct.
Which is a wonderful statistic.
It is.
But as it turns out, some of our therapies, while very good and directed at cancers, do have some effects on the heart and the cardiovascular system. Can you comment just a little bit on what some of those might be?
Yeah, most all therapies have potential cardiovascular implications. Some are directly cardiotoxic, such as anthracycline therapies. Mm-hmm. Other therapies, and those are traditionally the ones that are most commonly mentioned when we talk about cardiotoxicity. But there are many evolving therapies, such as in the breast cancer world and others, where there are direct cardiac effects. There may be secondary effects, such as volume shifts, systemic hypertension. And then it shouldn't be forgotten that many therapies include radiotherapy, which obviously can affect the valves, the myocardium, the vasculature such as the aorta, and obviously can enhance the opportunities or accelerate the opportunities for coronary artery disease.
Yes. And in adults, we kind of look at things as kind of length of exposure. So if our patients are in their 60s, 70s, or 80s, their exposure to these potential toxic effects is relatively brief, but in pediatrics, there's a very, very
Correct.
long exposure.
And I think it should be remembered there are data out there, very compelling data, that effects on the myocardium and on the vasculature can be seen within hours of delivering chemotherapy. However, your body seems to accommodate these reasonably well. So you may see subacute effects, you may see chronic effects. And it's been our experience that it sometimes may be a decade or decades before evidence of myocardial involvement may present.
Yeah.
So one may argue that surveillance is potentially a lifelong issue, especially with those children and adolescents that have been treated for cancer and are effectively treated. It should be mentioned that the cure rates are quite high in pediatric cancers, and patients and families should recognize that they may do very well from a cancer therapeutics perspective, but they need to be cognizant of the potential risk of heart failure, cardiomyopathy, vasculature, coronary disease, valvular disease. All of these things may be part of their future.
Yes. And I'm glad that you mentioned the vascular part, because in the adult world, we certainly see accelerated atherosclerosis. Coronary arteries, the aorta can be involved, the carotid arteries can be involved. But let me follow up a little bit on the point that you made, and that is surveillance. So can you share with our viewers a little bit about the program that you have at Children's and how you follow your patients?
We have a very strong relationship with our Cancer and Blood Disorders Institute at Cincinnati Children's. And with this, we've actually tried to be as proactive as we can be about surveillance for cardiotoxicity. So we've formalized a program that has recognized leadership both from our Cancer and Blood group and from our Heart Institute that are actively engaged in not only in research efforts, but obviously in the clinical surveillance of these patients. And we've tried to tailor those surveillance programs to the patients and the therapy specifically. So those patients that have received radiation therapy, those patients that have received different types of chemotherapeutics, we would try and employ a very regimented surveillance program for those patients, which may include non-invasive imaging, it may include blood pressure surveillance, it may include imaging of the vasculature, and other non-invasive assessments of early vasculature involvement, such as distensibility, compliance, and we've used advanced imaging techniques such as MR and other modalities in appropriate patient situations. I think the important takeaway is it's not so much always about the type of testing, is that you are being followed and that you do have a plan in place, and that patients should recognize that they are really never out of the woods. The risk factor never completely goes away.
Yes, so you continue to follow them. As a part of your survivorship network, are they aligned with one another?
It's becoming more and more aligned. In children's cancer, the Children's Oncology group obviously has been very involved in parallel efforts and sort of cohesive approaches to childhood cancer. And I think that more and more cardiac surveillance is becoming a part of the forefront of those discussions. Such great strides have been made in survivorship, and now you have to be thinking about what are the other opportunities to decrease mortality, to increase longevity, to improve quality of life. And much of that is going to be focused on cardiac implications of these therapies.
Yes. You know, in the adult world, there is an emerging literature on preventing some of the cardiotoxic effects, beta blockers, ACE inhibitors, statins. Similar literature in the pediatric population?
You know, unfortunately, there's not as much literature in the pediatric population, but we hope to be driving some of those papers in the near future. You allude to some very important topics in adult cardiovascular medicine. Being an adult cardiologist, we do see a fair number of adults, obviously. And one recent example would be the use of angiotensin receptor blockers as a potential preventive strategy in chemo exposures. I think you have to recognize that there are potential confounders and heterogeneity to these populations, obviously. And we can't forget that there may be underlying comorbidities in our adults. They may have systemic hypertension, they may have pre-existing coronary disease, other things that may predispose them to even more profound phenotypic events related to these exposures. However, that would be fantastic if we could develop a preventive strategy. We are thinking about that in children, as you know, to use drugs as a preventive strategy in a pediatric population. Safety always has to be of the utmost focus. And so we are engaged in discussions with other institutions about potentially employing things such as beta blockade, such as angiotensin receptor blockers, as a preventive strategy to follow these patients longitudinally and see if we could mitigate some of the effects of these exposures.
Yes. And for someone that has some of the cardiotoxic effects, treatments?
So typically we would employ conventional therapies, and a lot of that's going to depend obviously on the cardiovascular phenotype. So treating things like systemic hypertension obviously would be important, but also marrying that with surveillance of kidney function and other things that might be exposed as a part of these treatment strategies. Myocardial disease, we would pursue traditional myocardial dysfunction therapies. For those patients with heart failure and with reduced ejection fraction, we would apply guideline-based therapy. I think part of the importance is that many of the patients come back to us with a real question about, I have existing cardiac disease, but my cancer has recurred. I need additional therapies, or now I have a new malignancy that might expose me to other potential cardiotoxic agents. I think that that's a burgeoning area where treatment strategies such as we're talking about are very important to try and mitigate some of the potential outcome in those situations, setting them up to be in as good a position as possible when they're going to get that second, third, fourth exposure to chemo.
Dr. Jeffries, I'd like to talk a little bit about the unique aspects of the children's program and also things that we can do together as a part of an integrated program.
So as you and I have had extensive discussions about this, I think this is a unique opportunity for the city, for the region, and for our two historic centers. We have all of these patients that are surviving into adulthood from our pediatric cohort, and obviously this robust population treated at UC, all of which by definition are potentially at risk for cardiovascular involvement. I think to have a high-level cardio-oncology program really is not just about treating patients, which I think both institutions do very well and leverage the tremendous resources that exist at both. And we've had very effective collaborations managing patients, both from Children's coming to UC and UC coming to Children's. But it's more so about how can we prevent this disease, how can we understand the mechanisms. And I think that the basic science and the translational science that exist here at UC as well as at Cincinnati Children's afford us a very prime opportunity to understand the processes behind cardio-oncology, the pathology, the pathophysiology, and potentially be targeting therapies. As you know, in heart failure and coronary disease and other diseases, we're trying to be more mindful of a tailored approach to treatment. And I think that's really what's needed in cardio-oncology, not only as a preventive strategy, but as these patients progress and mature, how are we actively treating and anticipating needs of the cohort in the future. And I think that that's something that we are extremely well positioned to do.
Yes, I agree with you. And it's kind of been an interesting journey when you look back into the 1970s and the original reports with the anthracyclines. I think we've come to understand some of the myocardial toxicities, but what we're seeing a fair amount of now are some of the subtleties where blood pressure has changed. And our patient population traditionally is one with a very high incidence of hypertension. So we're looking at ways to, of course, give them the benefit of these newer therapies, but being mindful of changes in their therapies to make sure their blood pressure is not out of control.
Well, and I think that that's why a dedicated approach is important. If you have someone managing the myocardium, someone managing the vasculature, someone managing the malignancy, without crosstalk, that patient will not do as well as they could. Yeah. And so understanding these ventricular arterial coupling mechanisms and other things is a unique opportunity. And it really gives you targets that aren't currently taken advantage of in the current milieu. Yeah. So I think that it's a robust research opportunity. Mm-hmm. And the findings of that may impact the general population. But I think cardio-oncology is such a unique group of patients that will inform us that really is somewhat underserved in the current area, in the current era of cardiovascular research investigation. Yes. I think that's something that we need to really pay attention to.
You've made a couple of very, very important points. First of all, having a research platform, ways to study so that we can anticipate what the potential effects might be. And then as we follow individuals, what is the ideal means of tracking and identifying, preventing, and then treating if need be.
Yes, so,
thanks so much for joining us on Scholarvision today.
Thanks for having me. It's a pleasure.
It's our pleasure to have you. I'd like to thank Dr. John Lynn Jeffries for joining us today on this episode of Scholarvision. We've talked a lot about the emerging area of cardiovascular oncology, what some of the causes might be, including chemotherapy, radiation therapy, or their combination, how we can identify some of the potential effects on the heart and the vasculature, how we can treat some of those effects, and very importantly, research platforms that allow us to better understand who may be at future risk. Until next time, please keep asking questions. Inquiry is the true compass of scientific and scholarly advance.